Good morning. Good morning, everyone. Really, thank you for joining us. So we're going to start first live sessions from the Asan Medical Center. This year's, as you know, our meeting is the 29th TCTAP. So actually, this session is one of the opening, right? Okay. Asan Medical Center, Duk-Woo Park. Are you ready? Can you hear me? Duk-Woo, can you hear me?
Okay, I can hear you well.
Okay, here we have very distinguished, moderator is a panel here. Dr. Spencer King is here, and many panelists is Dr. All right, I just comment on that. Dr. Gerber, Goldberg, Jafary, and Janorkar, Dr. McLean, and Dr. Lee, Mehta, Dr. Song, Dr. Wagatsuma here. So this is the first case session, right?
Okay.
Would you introduce that one?
Thank you for joining the TCTAP 2024 in the Songdo, and welcome everyone, new convention center. And I'm very happy to present first live case demonstration. This is a very thoughtful case, and a lot of debate would be expected in this case. Before starting our first live case, I'm gonna introduce our team. And so I'm D.W. Park from Asan Medical Center, and the first assistant, Dr. Kyusup Lee from the Daejeon Songmo Hospital, and she was our previous fellow, and the current senior fellow, and the second assistant, Dr. Su-Yeon An. And we will start the first live case demonstration. Okay, Dr. An, can you present the patient background?
We have a 73-year-old female patient referred for chest discomfort. A coronary CT scan showed severe stenosis of the mid-LAD and moderate stenosis of the left main coronary artery. Next. The patient had no medical history, and she presented with stable angina with CCS functional class 2. Next. Electrocardiogram showed normal sinus rhythm with heart rate of 70 beats per minute, and there were no specific ST changes. Next. Chest X-ray showed no cardiomegaly. There were no signs of congestive signs. Next. Coronary CT angiography showed left main disease in the ostium, and there was diffuse calcified stenosis in the mid-LAD. Next. Echocardiography showed normal LV systolic function without regional wall motion abnormality. Next. And this is the baseline coronary angiogram. RCA had a mild stenosis in the distal part. Next. And in the color view, you can see the big OM branch with diminutive distal circ. And there's a ostium to shaped left main disease. Next. And LAO cranial view shows diffuse stenosis in the mid-LAD. And the spider view shows left main disease in the ostium and involving the body part. And the syntax score was 23 points. Next.
Okay, so it's a previous slide. So, and we're gonna very debatable portion. This patient is presented with stable angina, CCS class 2, the not unstable angina, and the coronary CT scan that shows the moderate left main disease and the middle LAD, very severe stenosis. The reason why we do coronary angiography. So today we check the coronary angiography. This is aerial coral view, and you can see the plaque suck in just a mild intermediate region, and the left main ostium, as shown in the prior slide, and it looks like a visual estimation, just 50%. And then next view, the coronary angio. So, and next view. So this is a much clearer view, and we can see this is aerial cranial view, and we can see middle LAD and the very tight stenosis, and prox LAD and the visual estimation seems like 50% and the 60% per the physician, and the degree of stenosis is somewhat the variable. So absolutely, and this is a very debatable point. How do you treat? And the first decision making, and PCI versus bypass surgery, syntax score is 23. And also, if you decide to the PCI, and what is your first strategy? If you just do angiographic guided PCI, or if you just do some FFR, or if you just do imaging guided PCI, and that would be first debatable point. Okay, SJ?
Okay, so it is 73 gentlemen is remain visually is more than 50%. However, the spider we showed a little bit less, stenosis, so the main areas. However, significant disease of mid-LAD, and so also from the panel. So, anyways, what do you think? A good candidate for surgery, or all right, why not?
Thank you, Dr. Park. Yeah, I think it's a mild to moderate disease at the left ostium, and there is downstream lesion in LAD. So FFR is not going to help. I would certainly do imaging, and that to ostial LAD, IVUS would be better than IVUS would be better than OCT, and then take it forward. Since this Asian population patient, Asian subset, so 4.5 square millimeter would be ideal cutoff, according to Dr. Park. It is described in the Western literature 6 square millimeter, but I would do IVUS of left ostial, left main, and then take it further.
So, DW, it's as someone who's not doing them actively, I have to ask these questions. First of all, IVUS, I'm convinced that left main, you usually use IVUS. The thing that interests me here about selection of how to do it looks like there's no obvious stenosis of the circumflex ostium, and a single stent looks like a good idea. But the proximal LAD, there'll be an interesting question about how you size things with the proximal LAD being 50% or so, and then the left main together. And then, of course, the mid-LAD with severe stenosis, and how you're proceeding with those various selection of equipment. So I'm going to be very interested in how you approach
Anyway,
that.
Spencer, it would be candidate for PCI, right? PCI is okay, right?
This is a candidate for PCI. I have no argument about that.
Big changes, right?
I think this is a very interesting case. I mean, if you look at that left main in the view that's being projected, it is about the size of the mid-LAD. So you can sort of automatically infer that that left main has a huge plaque burden. So what I would do is I would image the left main, and I would obviously stent the mid-LAD. And my inclination would be to lean towards fixing the left main also, because for longevity of the procedure. Otherwise, this patient will come back. But what I would do is after stenting the LAD, I would put a pressure wire just to get a sense of what the pressure losses are after the LAD is fixed. My gut feeling will be that you're going to have to fix that left main.
Right. So, Dr. Bak, how would you do that? And so do you have any...
Okay, go ahead.
Would you introduce some, strategy, your strategy, and a brand new, study about
Yes.
Fahim main
So,
subject, right?
Okay, so usually, this patient, literally is a tandem lesion, and the mid-aortic part in the tubular, very severe stenosis, and the proximal LAD, and the relatively intermediate region, and the left main disease, and it seems like an intermediate region, we don't know. And we already checked the imaging, but I'll let you know it's a final the imaging. Just in the contemporary PCI practice, when you decide to treat or not treat, we should do angio-guided PCI versus FFR-guided PCI. Usually imaging was used final optimization. So, and such like intermediate lemon disease and some IVUS criteria was used in Western country, 6.0, less than 6.0 IVUS minimal lumen area is recommended some revascularization. In Asian data, it's a 4.6 recommended revascularization. That value, 6.0, 4.6, was based on FFR value. The reason why we treat or not treat should do functional physiology or angiographic guided PCI the strategy. So I'm gonna briefly introduce our is now launching new trial. It's a FATE main trial. FFR evaluation is as the presence of Shamir Mehta is done some various clinical spectrum. It's a STEMI, multivascular disease, non-culpable region, intermediate region, and the multivascular disease, and many diverse spectrum. FFR lower was tested, and some trials showed 5 positive results, some trials shows a negative result. Next, the remaining part, FFR guided PCI could work in Wen-Lieng disease. That was our rationale hypothesis, our clinical trial. This is some brief scheme of the FATE main trial. We're gonna enroll more than 900 patients by visual estimation, more than 50% with randomization, FFR guided PCI versus angiographic guided PCI, and the hard endpoint at 2 years will be evaluated. We just started launch it, and the funding was completed for this trial. This patient was a randomization, the FFR guided PCI group we do, and the FFR was widely used during the PCI for treatment decision making. So we already checked up the FFR, and next one. So this is absolutely the tandem region, and we use the intravenous adenosine the infusion and the use the hyperemic status. As shown this figure, and the distal mid-aortic very severe part, distal portion at the hyperemic status was 0.45 FFR value, and the upper part of the middle tight stenosis 0.85. Its delta change was nearly 40 and 0.40. And the proximality, just the ostium part is 0.87, at the left main ostium is 1.00. Is then meaning is there is some thinkable information for how to treat this portion. So, and the selection is first to treat the mid-aortic part and then recheck the FFR. So at this moment, I'd like ask some panel, how do you think about, you just do, the full, the metal jacket from the mid-aortic part to the left main, or any another option for this patient?
Okay, it's great. If you have some, physiological concept, it's a typical example in terms of tandem lesions, right? If you look at the far distal, we know that the middle portion of an LAD is significant. However, we want to get some FFR value of 0.45. The reason why the difference between the value of FFR would be directly related of severity of the region itself. Which one is more tighter? The difference is mid portion of the difference is almost 4.4. That is biggest number. The distal lesion would be the tightest one. That is the kind of a tandem lesion selection concept. So based on these FFR findings, mid portion lesion would be treated first, and then you're going to do the FFR again. Okay, Dr. Duk-Woo, is it okay?
Okay.
All right.
So we already do the pre-dilation using the 2.5 balloon. Okay, angio over here. Okay, angio ready. Okay, we already do the FFR, the predilation, the implantation. Could you show us the angiogram at the time of the predilation? Is angio. We do, and the 2.5. Okay, no, previous. No, previous. Yes, this is 2.5 and confined balloon, and the same view over here. Yeah. Okay. Mid-LED part. Okay, this is 2.75, and for optimization, and we use the IBUS image already, and the final we show is IBUS finding. Okay, test. 자, 이 정도. 자, 테스트 again. 자, 이거 한번 찍어볼게요. 딱 맞는 것 같아. 그죠? 자, go ahead. Go.
So what size? What size?
Just
What length?
275. Okay, deplete. And then the 2.75 NC balloon. So, and the many audience and the panel would be interested how the FFR value was changed after fix up the mid-LED part. Is as you mentioned, the Dr. Janorkar, the downstream disease FFR interpretation is sometimes very difficult, but it's just like this tandem region. After fixing of the distal left main lesion, we can reassess the physiology significance of the left main disease. That was our rationale of the Fate main trial. Okay.
So first of all, I'm not surprised at all by these FFR values you had. And what you're looking at now is with increased flow, maybe to the distal, you're seeing if you have your FFR will become more significant with the proximal part. I'm going to be surprised if it is, but we will see.
6, 8,
I may be surprised.
Right.
10, 12.
All right. So we
Say,
published a tandem concept, just like explained.
10, 12.
The big delta of FFR value related with the separative region itself, right? So,
Deplete.
okay. NC balloon,
Yeah, this is at 2.75 NC balloon.
high pressure, what pressure?
Okay, go. It's a high pressure 16.
16.
Yeah, 2.75, 16, 18. Okay, deplete. 밑에 한 번만 더 하자. 자, go. 10, 12. 14.
Isn't it,
Okay, deplete.
Dr. Park?
And then nitro, and then recheck. Okay, go ahead. Okay, nitro 주세요. Okay, go ahead. FFR 준비하고. Okay, angio ready. 천천히. 자, angio. 라이트 들어갔죠? 풀샷. So, and we fixed up the distal part of LED. There was the milking portion, and there is no flag. And the middle LED part, we fixed it up. And so, and we just remaining the left main and the prox LED. You 한번 더 좁다. Test.
Some hedginess of the distal part of stent and soju.
Okay.
FFR first?
Yes.
All right.
Can I ask what the left main looked like on IVUS? What was the plaque burden, the
Okay,
area?
한번 줘봐, FFR. So, and we already checked up IBUS, and IBUS some provided some important message, but is a treat or not treat was initially based on the FFR value, and then we are finally showing the FFR view, the imaging view. The distal LED part was a negative remodeling, as already checked up the IBUS. Okay, here. 요거지. 자.
So you've taken care of what's causing the angina.
잠깐만.
That's already fixed.
자, 여기서.
The angina is fixed at this point.
제로 맞춰져 있어? 자, 제로.
But the question is,
오케이.
what about the proximal stuff?
Okay. equalization.
Interesting.
셀라인 한번
Since proximal part LAD and left main would be functionally how much severe, since we're going to measure FFR first and then match with the imaging dose.
오케이, 자
So
들어갈게.
we do
토크 달고.
zeroing again.
Yes, we perform the zeroing and then I should like cross over the FFR for the digital part. Okay. 자 여기서 이 정도 봐도 돼. 어차피 저
Can I
보이는
ask
게.
if you're
오케이.
using intracoronary or intravenous adenosine here?
자 여기서. Okay, we are usually use intravenous adenosine. Okay, adenosine confusion.
So you can do a pullback
Okay,
as well.
we will the baseline is 0.82, 0.83. Okay. Okay,
Yeah.
주세요.
Must be positive. So however, we're going to see what's happening. PDP.
Yeah, 0.882 was just the distal stent area, 0.854. Okay, hyperemia is not induced yet. 쭉 떨어지네, 아직. 자, 안 떨어지지? Okay, 0.69, 0.769. Okay, just pull back, 0.7070. Would you like the pullback over here? Just the distal part 0.74 and the proximal part of the stand over
Okay,
here.
there's a bone.
Yeah, 0.79, 0.79. This is absolutely hyperemic the status, 0.79 over here. 0.79, and then more pullback over here. This is distal part, and this is just distal main is 0.99. So, and main ostium was 1.0. So.
Very interesting.
we check
Very
it up,
interesting.
Yeah, we
Wow.
check it up again. The proximal part of the stent 0.79. So and based on the FFR value, and this patient would be the candidate for the revascularization. So at this moment, I'd like to ask some panel. What
Alright.
would you gonna do?
Very interesting, right? How do you explain that one? Distal part 0.7, immediate, above the stand is 0.8 something. However, main areas almost, controls 0.9.
So most of the pressure losses are in the stent. So I think one has to image the stent and see if you're optimized, because I think you're seeing most of the pressure losses within the area of the stent.
괜찮아.
All right.
I'm still worried about the left main though.
Spencer, this is, tandem concept, would be, look at this. Far distal 0.7, above the stand is 0.8,
안 돼?
and then almost proximity, the main areas, the
아이고스 한번 새로 보자.
delta difference is 0.2, right? However, between the stand, right, proximal distal just 0.1 FFR, delta FFR. So, based on the tandem concept, is main significant stenosis would be related to proximal LAD part, diffuse disease, and then we're going to see the odds, and we're going to match how much it will involve. And so that's the basic rule in terms of tandem concept. Distal stent, proximal stent, the delta FFR is 0.1. However, above the stent and proximal part is 0.2. The delta FFR value is clearly bigger, than the distal.
I would say, from my perspective, you've got a long distance to travel, and some pressure has dropped over this whole distance. I don't see just a real acute change anywhere. I see a gradual increase, a gradual decrease in the gradient as you go back. You've got a little bit of lesion distal to your stent. I don't know if that matters, but to make a decision on the left main based on all these numbers
negative remote.
seems against your concept of the prevent trial,
Could we
which
not
I'm more
FFR
interested,
the
not in,
circumflex? Is
I
that
think
not
you've already
possible?
cured the angina. You've cured
So
the
we're
angina,
gonna-
but you've not
Yeah,
convinced me
we're gonna
that you
open
should not
the
treat the...
Pandora box and for the.
But
the
what
IBUS
about
and-
FFRing in the circumflex?
Stent,
If that's negative,
this is
then
a
the left
stent.
main's
Yeah.
normal.
at least more
Stent was
than,
well exposed and the distal stent, as you can already see that there was a negative remodeling at the stent distal part. There is no dissection, there's no inner position, and we did 2.75 high press balloon dilation and up to the 18 and the 20 ATM, and the upper part, what happening? We would like to open the Pandora box, and if you have some information, the IBUS guided imaging would be very much helpful to understanding why the FFR value slightly some compromised and is very understandable. And this is the prox the stand part and well opposed over here. So we're gonna show the upper part would be more interesting, and the edgy portion there is no dissection, and as you can see here is some plaque, and the vessel size is 3.25, 3.5, and the plaque burden is not much, and just 30% would be okay, and this is the prox middle part is okay, and the plaque over here,
Some plaque here.
and this is a prox LED,
all right?
yeah.
Getting
And
more.
then we are showing the full examination of the imaging for the prox LED to the left main. This is a prox LED. You can see there is some plaque burden. Here is a 60, 70%. This is a LED ostium.
Lots of plaque
It looks like a
over there.
huge plaque. And at least more than 70%.
Prox
This is
LED, right.
attenuated plaque. This is a prox LED part. and
Still
the huge
proxerated,
plaque.
right?
Yeah, still prox LED.
Great.
And then we can see after coming the suck, the 3 o'clock, and there is some
Suck of
distal left main part over here, and the plaque burden here is the 67%. This is the target region of the left main, and this is a left main ostium. That we open the Pandora box is imaging imaging information for proximity left main. So FFR for the just that region, this is part 0.79. So on the basis of the FFR value, we would like the full cover to the mid LED and left main ostium. So what we're gonna do is after seeing the IBUS information.
The same thing you would have done had you not done the FFR. So what if this FFR had been had not been positive? You still would have done IVUS, I think. I think you should still do IVUS because what you're finding in the left main and the prox LED, this patient probably won't have angina. This patient's angina has gone away. But what we're worried about here is what if you have something changes about the left main. So I'm interested in your predictive capabilities. You don't have a near study. You don't have that, but you don't know the OCT. You don't know the cap thickness and all that stuff. But this has raised enough question to me to say I would be uncomfortable leaving behind the left main and the prox LED.
그렇죠. 그럼 아까 얘기한 대로.
Michael, you have any
Yeah.
suggestion to that?
Based upon IVUS, what I would do is there's a reasonably healthy segment in the prox LED. Proximal to that, I would put maybe a 3.5, 28, and then overlapping that, I'd probably stent over the left main. So 2 stents, 3.5, maybe a 28, and then overlapping with the left main, let's say 4.0, 18 or 23.
So, Dr. Duk-Woo, what did you do that?
So, and the upper part of the stand is FFR value was 0.79, and the plaque was overall extended from the left main to the proxy LED, mid LED part. In the left main ostium is a 3 point, lumen area is a 3.9, and we would like the, based on the FFR values, our cut point was 0.8, and the main trial, but this patient showing the 0.79 after fixing the mid LED part, and we decided to full cover the stand from the main ostium to the mid LED part. Okay, IVUS measurement is the 47 lengths, and we're gonna fully cover from the main ostium to the mid LED part. Okay,
Very interesting. All right.
Hi,
So
sorry.
another option here is to do OCT imaging, as Dr. King said.
Hi, good
Have
morning.
a look at
Sorry,
that proximal LED
just wanna make
plaque.
a-
And if
just
it
wanna make a
represents
comment. My
thin
name's
cap
Pinakin.
fibroatheroma, then consider stenting
the
it.
left main has severe disease or looks quite abnormal. The pressure wire that was done, I just want to be clear, was there an effort taken to do the pressure equalization in the aorta? Because, if you are equalizing in the left main, there's a chance your pressure wire readings might not be as accurate because of the disease inside the left main. So I'm just wondering whether the pressure drop between the ostial LED and the left main, which was 0.99 to 1.0 across the left main, was it because the pressure wire was really in the disease segment and not equalized in the aorta?
So at the time of the equalization, I pulled back the left main ostium. That was, as you mentioned, that was a very critical point in the left main, the physiology evaluation. Absolutely, we should pull back the caster out of the left main. That was it's a basic principal part.
All right.
Okay, thanks.
So, okay.
I think this is stable coronary disease, so it's important to look at the plaque morphology here. And if that's a fibrocalcific plaque in the proximal LED, it's very unlikely to rupture. And as Dr. King said, you've taken care of this patient's angina already. You've opened up the most significant lesion. So I think, certainly in our center, we would be doing OCT imaging and looking at the plaque morphology and that proximal LED lesion.
Okay, testing.
So what size? What size
This
of
is
stand?
3.5. Okay.
What length?
수줌인가? 48. Okay, test.
48.
오케이. 자, 엔줄 찍어볼게요. 천천히. 자, 오케이. 풀샷 slightly hanging out. I think it's
very
good.
interesting.
Okay, go. In play. 12.
I think part of the issue is that, ischemia, this patient would not be in the ischemia trial with the left main disease. And so you have to ask the question that, what is the longevity of your procedure and what is the prognostic aspect? The angina has been taken care of, I agree. But if you leave this, it's very likely this patient will be back with something. And now with the PREVENT data, you even worry about, a prognostic aspect to things if you leave such heavy plaque burden, fibrolipidic plaque. So we would have stented this. I agree fully with what the operators are doing.
Yeah. So I'd like to want a question to the panel and the audience. Conventionally and the classical concept, the significant left main disease, and we are usually, by angiographic, the diameter stenosis more than 50% would be a candidate for revascularization. Over the last 15 years, most of the clinical trial from the Syntax, pre-combat, Noble, Excel trial is adapted the same categories. Visual estimation, angiographic estimation, more than 50% would be suitable for PCI versus bypass surgery. But nowadays, some review article and Dr. Mario Gaudino and Dr. Christopher Malaise and showing some intermediate left main disease and 50%, 70% is require we permit the medical therapy alone. There was some the concept paradigm change of the left main disease. And nowadays some change in the angiographic guided more than 70% revascularization. Intermediate zone would be do some more thing, FFR or imaging. That was adapted in the Excel trial. In the Excel trial, visual the angiographic diameter stenosis and more than 70% is 50%, less than 70% was 50%. That portion do additional IVUS imaging or FFR imaging evaluation, the treat or not treat decision making. that was the main rationale for the FFR guided PCI could work for even left main PCI, and that was the rationale of the Fate main trial. So, and my question is about the audience. How do you do such like a 50%, 60% angiographic left main diagnosis? You just do the PCI directly, or you just do and the FFR, or you just do some imaging evaluation? That is, I'm wondering, is now current practice in the world, in another country?
For FFR, I think we are a little skeptical if it is, multiple tandem lesions and particularly downstream lesion in LAD. And if you are evaluating left main, you are going to underestimate left main definitely with FFR.
3.5지?
So I think it is little limited value of FFR in as far as multiple lesions are concerned. And now here I just want to ask you, since you have done crossover stenting, are you going to do FFR of LCX also? Dr. Park?
So LCX, is after after the checking, after high pressure and the leaflet, and by checking the angiography, we will decide to FFR. After stent crossover, angiographic stenosis was suspicious of osteum. FFR could work. There is some data. FFR more than 0.8, and the deferral therapy would be okay during the 5-year follow-up. That was published in the additional Korean data. Okay, go. 6, 8, 10, 12, 14. Okay, deplete.
Dr. Song?
Okay.
And go on.
Yeah.
6,
In my
18,
opinion,
20.
in case with 50 or 60% of left main lesion,
Okay,
I think that we have to do some imaging, I think, rather than the FFR. So there is a high probability to perform PCI. So imaging is also very helpful for the conducting the PCI. So
Right. So main disease, this is very, interesting cases. If you look at just only FFR, immediate after stent, the difference between the above the stent and proximal LAD, almost 0.2 something. If you separate, it is almost technically impossible. The reason why you just cover the 48 stent, right? However, if you separate proximal LAD only, there is some normal-looking area of a distal shaft area. The main osteal disease is not so significant if we do evaluate, right? However, we cannot separate by technical aspect. The reason why main, very short limb main, etc., etc. So we know that the stent itself is okay for long-term outcomes, and so the reason why we just cover the whole lesion. So, however, functional concept, the proximal LAD would be main, the issue. So for we got some idea, and then treatment is quite similar with the angio guided, FFR guided. However, this concept is a little bit different, right? Very interesting cases, right?
So Mark, when you
evidence-
have tandem lesions, one option is to put a pressure wire in the circumflex and see what the left main FFR is like. I think Dr. Firon has published that and shown it very nicely that the FFR across the left main into the circumflex would reflect the left main severity. So that would be one option too.
Yeah, that is good suggestion. Yeah, I read that article is very informative. So, and some interventional cardiologists ambiguous in what you're gonna do treatment decision, treat or not treat based on physiology or based on imaging. So if you look back the initial time point, in Excel trial, intermediate left main lesion, and they allowed the two thresholds. One is FFR less than 0.80 or IBUS minimal lumen area less than 6.0. So we think about originality is that IBUS 6.0. This threshold, where from? That is based on FFR guided. There was you may remember 20 years ago, Justice data and the 6.0 minimal lumen area was derived from the FFR measurement. So, and the original, the starting point was FFR. Yes.
Okay, good.
So, in the previous view,
I was,
so I think angiography, the final angiogram was looks good, and As I already mentioned, there are many debatable points in how FFR could work in left main intervention, and just doing if you select angiography guided PCI, it's very simple. But if you do FFR guided PCI, there are many thinkable points during the procedure. But that is one sort of a dynamic procedure of the left main PCI. We now do state-of-art PCI, contemporary art PCI. We many very useful argument is about the imaging and the FFR like this. Okay, go. So, and the distal LED part was negative remodeling over here. Stand transition part over here is good. It's no inner position.
Diameter is 2 and 2.5.
Yeah. Yes.
Maybe stand area is almost 5 something.
Yes.
You can guess that one, right?
So, and to shorten the time, I would like a manual pullback, and this is middle LED part is well expanded, and okay, this is the two-stand, the overlap zone is good, and I would like to do manually pullback. This is the proxy LED part, is a huge, widely open. This is giant stand 3.5. We inflated up to 20 ATM. This is LED ostium. I'm going to show them. This is a 0.5 milliscale. Okay, go. And the proxy LED part and the widely pullback over here. Okay, good. This is proxy LED part. Circle is coming. The 4 o'clock over here. And this is a distal left main. And stand was the expanded well. This is the stand was 2 millimeter. It's protruding the left main ostium. It's we fully covered the left main ostium. So I think if you're gonna do just angiographic guided PCI, it's very simplified. But this patient's randomization was FFR guided PCI. The final result was excellent. We will check it up the final angio. Okay, angio ready. Full shot. Good, good. So
Perfect case. It's right.
Coral view.
All right.
Full shot. It's good.
Great.
And finally, spider view. So, and,
Spider.
okay, good. Full shot. It's good. So I think during the 3 days TCTAP session, we have many times to discuss and what is the most debatable point of left-main PCI and the revascularization strategy. I'm sure you can expect it much for, we will have a very nice lecture for this.
Good.
Actually, any final comment?
Dr. Bach, thank you for nice presentation. So see you later. So we wanna move second cases. Dr.
Thank
Han.
you, thank you.
Okay.
Good morning, Doctor.
All right.
Good morning, Dr. Bach. Can
Jung-Min,
you hear me?
Great. Look at this. From the first cases, if you do angio guided, FFR guided, final procedure consent, two-stand, crossover, it's okay, almost same. However, you're gonna do lots of, thinking, IBUs, physiology, and then finally we adapt, two-stand procedure, a little bit different. And so it's a small difference, I believe, can make a big difference in the late outcome dose.
You taught us to put one stent in this kind of case, and that was clearly right. We should only put one stent in the left. I mean, a crossover.
Right.
You would not do crossover in this case. I mean, you would not do the circumflex in this case, right?
All right.
No one would do that.
Okay.
I think.
I
think maybe somebody would.
Dr. Han, okay, will you
Actually,
introduce
I
your
would,
case first?
can I just say, I think I would do, sorry, down here, to your left. Yeah. Actually, I would have wired the circumflex. I would have FFR'd the circumflex from the left main, and I think I would have potted the final result. Because on the IVUS, it was underexpanded in the shaft and ostial left main. I would have potted with a proximal to the bifurcation. I would have potted with a with a big NC balloon, I think, and then re-IVUSed. That's how I would have finished this case.
Okay,
Okay.
Dr.
Good morning, Dr. Park and Professor King. Very nice to meet you again in the TCTAP 2024. Congratulations, Dr. Park, the nice day live demonstration. We also preparing the very complex PCI cases, including the left main bifurcation. So I'd like to introduce the patient brief history. Dr. Park is our senior fellow. Could you introduce patient history?
Okay, thank you. I am Hansu Park. Let me introduce this case. 72-year-old male was referred for chest pain. He has been treated with hypertension and dyslipidemia. The angiography showed diffuse stenosis at proximal to distal RCA and diffuse heavy calcified stenosis and distal left main bifurcation. We planned revasculation of left coronary artery. Next. His cardiovascular risk factor is hypertension and dyslipidemia, and clinical picture was stable angina. Next. ECG showed no significant ST changes. Next. Chest X-ray showed no significant pathologic finding. Next. Echocardiography showed normal LV systolic function and no regional wall motion abnormality. Next. Diffuse calcified stenosis was shown in right coronary artery. Next. In left coronary artery system, left main to mid LAD diffuse calcified stenosis and left diffuse stenosis at left proximal circumflex artery. Next. And next. And target region is distal left main bifurcation, LAD, and RCA. And planned device is IVUS and FFR.
Okay, do you have any comment or the question on this patient?
What is the syntax score here?
Main with diffuse disease and the RC disease, and so typical main with the three vessel disease, and so. What do you think? The surgery or PCI?
What is the syntax score?
Definitely more than 32.
Yeah. So it tells the story, isn't it?
Spencer, surgery?
You can't get the surgeons. The surgeons would operate on this one, yes. I'll talk tomorrow about why the surgeons won't operate on anything, but today they would operate on this one. But then the patient should have a say in this, and the patient probably is going to say, why don't you do angioplasty?
I mean, this is complex disease, so we would offer surgery as the first choice, and if it's a turn down, then PCI, complex PCI. There's a lot of calcium. You're going to need calcium modification, possibly atherectomy. So it's a complex case. Great case.
It's going to be a full metal jacket on that right, that's for sure.
I think it's a hard team approach.
So,
Yeah, I totally agree with your opinions. Usually Korean patients don't like to open their chest anyway. So we have two random trials, the pre-combat trial, best trial, to compare PCI versus bypass surgery in left main pre-combat, and best is multivessel disease. Both trials show that PCI increase the risk of repeat intervention, but up to 10-year follow, there is no difference regarding the overall mortality. So, yeah, different physicians, they may have a different idea, but based on our random trial, frankly, in fact, for even this patient, I believe that the PCI can show the comparable long-term mortality to the bypass surgery. I believe that, even though high syntax score.
Could we see the left again?
Left, could you show us left?
So Doctor, what would you do that for the right
So,
coronary
yes,
artery? Right coronary artery first?
Because of time limitation, I already finished. I already corrected the right coronary using the diffuse full metal jacket from the distal RCA to the proximal RCA. So it looks a very calcified lesion, but the procedure is very smooth. And then using the high pressure balloon, the calcium is well breakdown and stent expansion is very nice. So this is a TCTAP. We'd like to focus on the left main bifurcation. So could you move to the left system? Left main bifurcation, very calcified lesion involving the typical left main bifurcation lesion. Next. Spider view show that the critical left main disease involving the diffuse circumflex, the proximal circumflex and ostium and proximal LAD lesion. Next. So LAD lesion is very diffuse. Look at the left main. This left main is very tight. The shaft is very tight, and disease is extended to the mid LAD. Next, please. So first of all, we measured this patient also enrolled in the Fate main trial. So Fate main trial, we have to measure the left main FFR. You can see the left main FFR. The FFR value is 0.49 at the distal, and mid portion is 0.68. Definitely left main is below the FFR cutoff value less than 0.80. So we have to treat the left main, including the mid portion of diffuse disease. So because of time limitation, I already implanted a stent for the mid LAD using the 2.5 38 millimeter giant stent. And then now I'd like to focus on the left main bifurcation. So, ready? Okay, this is the left main bifurcation. As you may know, for the left main disease treatment, the IVUS intracoronary imaging is very important. Before treatment, we already obtained the IVUS imaging. Could you show us the circumflex pullback?
Great.
IVUS imaging. This is the circumflex distal landing zone. Vessel size is 275, diffuse disease. Some classification, mostly fibrous flow. Yeah.
Encircling, or then 180 superficial calcium, though.
Here is more proximal circumflex. Yeah. This is a very osteomobile circumflex. Could you go back?
Almost encircling, superficial calcium over there. Here we are.
Stop, please. Stop. Here. This is a very osteomobile circumflex.
All right.
And could you show us the LAD pullback? Skip the mid LAD and could you skip the mid LAD and proximal from the proximal LAD? Okay, start. Proximal LAD, the calcified lesion, but not 360 degree, just the 180 degree superficial calcification. Here is a very ostium and distal left main. Distal left main very tight, calcified stenosis. Okay, well,
looks like a calcified nodule in that proximal LAD.
Yeah, right. LAD is 3.25. Left main, distal left main, we can see the vessel size, but the left main shaft vessel size is 3.5 around.
Anyway, very bad, calcified long lesion subset. So what would you do there, Dr.
Frankly speaking, I do like to use the resorption device, but unfortunately in Korea, resorption is not available. Another choice would be the rotabulation, but before rotabulation, I'd like to apply the high pressure balloon first. Then if a high pressure balloon is not well dilated, even apply the very high pressure, I'd like to do rotabulation for circumflex and LAD. So this is, I already insert to the circumflex. This is just 2.75 high pressure balloon. We already knew the circumflex OSTR, the vessel size around 3.0. So 2.75 is safely break down the calcium lesion in circumflex.
I mean, generally, if I was always taught that if you think rotablation, you should just do it. So, what are your thoughts? I mean, one of the concerns I would have is if you dilate and then decide to do rotablation, you may A, have dissections and B, have to use a bigger burr. So,
dilated? What size
yes.
Wednesday?
275.
275.
Yeah.
You know, one thing that impressed me on imaging was that the calcium was not greater than 270 degrees of calcium, so which is actually surprising. I thought fluoroscopically it looks worse.
I agree.
But the fact that the balloon profiled nicely is consistent with the arc of calcium less than 270. So this looks like it's centric calcium. I think the balloon, the LED will also profile as well.
10.
Osteopatch? Great.
So no matter what you put in, you're moving everything away. That big chunk of calcium is just going to sit there regardless of what you do. So the question I have is
Complex osteum is
it
very
better to
important
grind out a
for
little
the
bit of
final
it, or,
result.
but it says almost
16,
all of it's
18.
going to remain.
So look at the balloon is well dilated, no indentation. That means the calcium definitely break down well. Depletion?
NC balloon works, right?
Yes. 10.
More.
I mean, this is where lithotripsy would work really well because it would pulverize the plaque out of the way, you know, and then you're going to get good expansion of your stents. It's a shame you haven't got access to it. I think rotablation after stenting and some dissection would be hazardous, and I'd only do the rotablation up front after the IVUS. I don't think it's a good idea to rotablate with stents.
You know, Rob Riley just put out a paper from JSCAI, and the initial strategy of using a balloon is a very reasonable option, albeit you should not go high pressure because if you dissect, you take away the option of doing atherectomy. But I think in this scenario, given what you saw on angiography, intravascular imaging, I think it was a very reasonable option. Try at least go with the balloon and see how it responds. But don't take
So
the
my
option of
bifurcation
atherectomy.
treatment strategy is the two-stent crush technique. So nowadays, many operators empathize the simple crossover, but definitely this case is the case for the two-stent technique. And my preferred two-stent technique is the crush technique. So I'd like to show you that how to do crush technique for this kind of very calcified bifurcation lesion. This is a high pressure balloon for LAD. And LAD, please, 10.
Balloon? You want to anchoring, right?
Yeah.
Great.
This is balloon anchoring.
Push into the stem,
Okay.
circumflex. It's quite
Deflation.
easy to, you can do that. Deflect the
Test
balloon. Perfect.
Okay. Test one more.
So with these two vessels, you
That's
could
a
do a
position
collot as
wise.
well because they're similar
It's okay,
size.
right? Great. Oh. All right.
Test. Okay.
Great.
Gotcha. Circumflex.
Circumflex stent first. What size? What size is stent?
275 stent.
275.
Deflation. So
You don't mention about the what kind of stent, you know? Giants or
giant. This is giant stent.
right.
So 10.
10.
So for successful crush technique, the circumflex ostomy is very important. So don't put out every device deflation. One more high pressure is very important. The full optimization and very expanded of circumflex ostium. Sometimes I like to do one more high pressure balloon. Give me the high pressure balloon.
You mean
275.
kind of a modified DK crush, you mean?
Yes, this is kind of modified DK crush.
High pressure inflation of osteopathy is sometimes very important to recross the wires, you know.
I'm impressed what you say about that because the circumflex ostium is the most common restenosis place, right?
Yes, it is.
So patient don't complain the chest pain and vital sign is very stable. So this is a kind of beauty of crush technique.
Big vessel, so we don't hesitate, you know, to stent.
U1 주시기 좋을 것 같은데. 네. Because this is use the one, the U1. I like to use the U1. Sometimes the circumference ostium or additional high pressure is not that easy, then I'd like to crush it if I fail the
So you want to
balloon
do
delivery.
bigger balloon, high pressure, circumflex ostium?
Yes,
Right.
yes.
What size?
275 high pressure.
High
Because
pressure.
the circumflex ostium, it looks like the 3O.
Great.
So you're putting an additional wire before crushing it. Is that what's happening?
No, this is high pressure before crushing.
Yeah.
10,
All right.
16, 18, 20, 24.
Circulation. What pressure? What pressure?
24.
24.
Yeah.
High pressure is
Yeah,
we
high pressure.
consider the what pressure? The 16, 24, and then
10. LED crush.
balloon crush force. Great.
Okay.
Perfect.
16, 18.
16, 18.
Deflation.
What size balloon is the crush balloon? 3.5?
This is 3.25.
0.25.
Yeah. 10,
10,
16, 18, 20, 24.
24.
Deflation.
Our findings show us some, encircling, calcium.
24.
However, NC balloon work anyway break down the
Deflation.
player cell. We don't need a road ablation for that.
Okay. After, I'd like to implant to the LED stand. We already measured the LED IVUS. So IVUS show the left main is around 35.
35,
So
main
this is
35.
yeah, this is 3.25 considering the LED size. Are you
Infrequently,
okay?
what has happened to me is that when a stent is put in from the left main into the LED, now you have two layers of stent struts which are obstructing the ostium of the circumflex. What I've done in the past is rewire the circumflex now, get a balloon to just at least open up the stent struts, then put the stent. And so when you wire the circumflex after you implant the left main LED stent, it's going to be easier to get the wire and therefore the subsequent kissing balloon down. So it just personal preference, almost kind of like a modified DK crush.
Spider?
But there's nothing more disconcerting than being unable to advance that balloon for the final kiss.
Okay. Test.
At the least, the middle portion of the main included.
So you're saying you don't do the kiss, you just open up the strut?
Initially,
Yeah.
to help
I mean, in
facilitate
DK crush, you do a kiss right now.
kiss right there.
Yeah.
But I'll just do a single balloon into the circumflex, just so that I won't have too much difficulty getting that kissing balloon to the circumflex.
Yeah, I do that as well, and it's a bit like what John Ormston described as a two-step kiss, for your provisional. So it's just a modified way of doing a DK crush. So you just do one step with a small balloon and rewire. And sometimes I leave the wire in the circumflex because it helps deliver the LED stent. I know it's jailed, but it just gives me a marker,
Some people have recommended to do a part crush, in other words, take a balloon size to the left main and crush the crush stent further before you recross. I'm not sure it's been systematically studied, but it does make some sense. It just adds another step, and DK crush has a lot of steps.
So this is another important step after crushing and balloon stent implantation to the LED. So before rewire to the circumflex, we have to optimize the LED stent, full expansion and full opposition. Particularly the left main ostium stent should be full opposition and full expansion. That makes it easy to rewire to circumflex. It is a concept of the part technique. Part technique facilitates the rewire. So look at, because of time limitation, I'd like to see the prox. Yeah, prox. Here is the prox LED. I implanted a 3.25 up to 18. around the final stand size up to the 3.4, well expanded.
Position is
LED
good.
Yes, there was some classification, but I applied 3.25 high pressure. I break down the LED classification well, so stand expansion is very nice. Look at there is some crushed area. This is left main and shaft 2. I think we need a high pressure for.
Big enough.
Okay.
Big enough.
3.25 high pressure, please.
You want to do
High
more
pressure
high pressure
using
inflation,
3.5.
proximal
Yeah.
part of stand.
Yeah. Ready?
Ready?
Okay.
Actually, I would say that's a 4 or a 375, but, you know.
But I was show that look show us that I was.
See that,
This
this
is
ibis I can
3.5.
see here, if you,
Yeah.
if you
Yeah.
measure it, it's a bit more than 3.5. I mean, I
Yeah,
think
it's
if you
35.
pot well, you see, it facilitates the wiring into the circ. It also prevents, I think, a restenosis in the circ. And as we know, the circumflex is always
10.
punished in this procedure.
10, 16,
16,
35.
35, 16, 18,
15,
18,
20,
20,
20. Still,
distillation,
some
24.
Dr. An, this is Dr.
Yes.
Lee. Can I ask you a question? Because the
Distillation.
patient don't have any diagonal branches. So the first septal
Yeah.
branch is a very important one. Would you like to now rescue it after you treat the left main?
Implantation. Okay, but the left main is more important than any diagonal branch. Patients don't complain chest pain. I like to focus on the left main first, deflation. And then if during the procedure patient complain chest pain, I'd like to rescue the diagonal, any side branch to relieve the pain, not due to the patient prognosis. But regarding the patient prognosis, left main is more important than any side branches. So now I'd like to focus on the left main first.
Well, I'm asking whether you have to rescue the septal branch. The patient don't have any diagonal branches.
Yeah.
So
Ready?
septal branch is also very important. It supplies the entire septum.
Usually I don't touch the septal branch. I don't like to touch the septal branch. Septal branch intervention, this is my personal bias. Septal branch intervention is not
and
sometimes.
and geographically it's good. So you want to do wire pass for the circumflex,
Yes,
right?
yes, right. After poor position of left main stand, it's kind of a pot.
I think the key for this case to prevent a TBR is to really optimize the ostium of the circumflex. You can already see it's somewhat not optimal, but I think just really pounding that ostium of the circumflex would prevent the TBR.
Yeah, right. So this is a used wire.
Great.
So I already applied high pressure before crushing. So circumflex ostium, I believe that it already widely opened and well expanded and well opposed. So this is 35 for LAD.
35 LED.
Okay.
Jung-Min, hi, this is Michael Lee. Great case so far. For you, when you rewire the circumflex, does it matter where you wire it? Does it matter if you're distal and coming back? This is the age-old question.
Frankly speaking, I prefer the distal rewire because to remain the short carina. But I'm happy if the wire go through the circumflex. I'm happy. I don't care proximal distal or middle. I try to distal, but any location I'm fine. This is a 3.5.
What size is circumflex? What size?
Initially 2.5.
Initially 2.5.
And are you
Yeah.
going to go with the NC, or are you
Open
going to go with a compliant
This
balloon
is a
cross?
compliant balloon used before.
This
which
angiogram
include
is so
LED,
interesting because the lumen of the vessel you see at one point, and then you see this huge calcified piece of the artery quite removed from it.
Circulation.
It's like a different, almost like a different vessel over there.
So I always take a fresh balloon when I go across. I know it saves a bit of money to use the old balloon, but honestly, I would say more than 5 times out of 10, the old balloon doesn't go. So I just get a fresh balloon, and it just saves time for the patient and the operators, you know?
Yeah, I fully agree with your opinion. I love new balloon. 10, LED 10.
And actually, the balloon really is only a few dollars. It's not, the balloon's not expensive.
Small size, right?
Yeah, 1.5.
1.5 balloon, compliant.
Inflation. Yes. Very well.
Okay.
Yeah.
Very easy.
Sometimes you can,
after the crushings, we, consider about the proximal part, distal pass, proximal pass. Do you believe that, Michael?
There's no evidence to say one or the other. I think if you pass, I think the main reason why people get TVR is because if you look at the initial DK or the crush trials, is people that the wire they couldn't pass, they're the ones that develop TVR. But if you get the wire through and able to do final kissing balloon, your TVR rates will be very low.
10.
The only modification I do to that is if the wire crosses and the balloon sails through like a bullet, I will look at it again and make sure I haven't gone very distal and maybe sometimes rewire, because if you go really distal, the balloon just flies through, and that's kind of it gives you a heads up that maybe you weren't optimally crossed.
But Dr. Lee, it's very difficult to judge whether it has gone distally or proximally, isn't it? Strangiographically?
So finally, you choose the NC
It's a
balloon?
275 high pressure balloon for circumflex.
sometimes you can use the distal
2.75.
or mid-LAD balloon as an anchor balloon if you struggle getting the side branch balloon in.
This is anchor balloon. This is the 275 high pressure balloon.
Exactly, that's what we're saying.
Circumflex 10, 16, 18, 20, 24,
High pressure
2.9,
circumflex system force.
depilation.
29, right. Sequential high pressure inflation, circumflex
LED,
force and
16,
LED. High pressure inflation.
18, depilation.
And then
Yes, I'd like to do a final kissing. The purpose of final kissing is to make the carina in the right place. I don't like to apply the high pressure because of safety concern. To achieve the large lumen, coming from the sequential high pressure dilatation, not final kissing balloon. I'd like to apply final kissing balloon. Pressure is just a low pressure, 8.8, please. Okay. 1, 2, 3.
Dr. An, it looks like the side branch, the circumflex ostium is not easy to open up. Would you like to consider just a sequential ballooning that dilate the circumflex ostium first and then add the LED stand, LED balloon? Do you think that sequential balloon is better?
For high pressure?
No, for the final kissing. Because it looks like when you inflate the balloon at the same time, the circumflex ostium is smaller than the LED. So why not inflate the circumflex balloon earlier and deflate it later so that it can keep it?
perfect. I like it.
I'd like to simultaneous inflation, but the balloon dilatation cannot control meticulously. That's why it looks like the sequential balloon dilatation. But I tried to the simultaneous final kissing balloon dilatation. So circumflex is a little bit pinched, but I like to check the IVUS first.
I think it's great.
Very-
Angiography, great.
Very complex left coronator disease involving this left main calcified left main disease, but it doesn't take less than 1 hour procedure. Go, please. So if you know how to do, then we can stratify the procedure itself, and it doesn't take too much time,
Just
and
a
patient
main
is
here, right?
stable.
Ooh, big one. More than 10, 12 millimeter squares. Then
Very ostium is hanging out the aorta, but 1 or 2 stroke, it doesn't matter. I don't think it affects the patient's long-term outcome. So I like to see the circumflex ostium. So this is the beauty of IVUS-guided PCI. We can see the inside of a vessel, not the angiographically, but the true vessel size. So I feel very comfortable. I apply the high pressure during the procedure because I already knew the vessel size itself.
it's circumflex. It's circumflex.
Circumflex, yeah.
All right, great. Almost more than 2.530, more than 5.6 millimeter square.
My
I
concern
think
is
it's quite
very
enough,
ostium.
right? Relatively small.
Oh, very
It's okay.
ostium looks small. Okay.
Some related with the corona shift. However,
Yeah,
you know,
I think so.
effective stent area is quite good, and don't worry about that.
Could you measure?
Great.
Okay. Could you measure the ostium? Previously, we published data 5, 6, 7, 8. Recently, we published the new data 6. But the 5.5, I think it's acceptable circumflex ostium. So I'd like to take the final shot. Ready?
Good, perfect. All right. Okay, it's just on time. It's a really nice case presentation. Dr. An, Dr. Wak, really thank you for this case. Any
Can I
special?
ask
All right.
one question? Because you guys are doing this and you're doing it so beautifully. But one thing that's always interested me is you talk about how long it takes to do things, but the shortest thing in the whole procedure is how long the balloon is inflated in the lesion. I see everybody do it. You go up to, it's about 1 second, 2 seconds. That's it. Now, if I think about tissue and I'm trying to move the tissue, am I as effective? And then we go to higher and higher pressure, up, down, down. I've always felt that maybe the patient could survive 5 seconds or something, even 10 with the pressure, and maybe something is giving, and maybe you get more
Yes,
effective.
I believe
So it's
that.
just something I've observed everybody does now, but I wonder if it's right.
All right, Dr. An, really thank you for your cases. Everybody enjoy your cases, though, right?
I'm very honored. Thank you.
All right.
Thank you, Say and Dr.
During
Spencer.
the last 2 cases, we've learned. Anyway, whatever you choose the main disease, right? Technical point of view, we can do that. This last one is really bifurcation, diffuse disease, calcified region. However, we can make a real good, angiography. In terms of long-term outcome, we got some data. So we've changed a lot. One issue is, Michael, we published the data, stent length at least 40 millimeter, it would be okay, right? Reasonable rate, TLR rate is okay. However, recently we do, getting better drug-eluting stent, it's a high pressure inflation, IVUS guided, and so what do you think is maximal stent metal jacket in terms of lengthwise? If we overcome that one, we can do everything.
And this is only the left main LAD or and cumulative RCA circumflex left main or LAD?
All right.
Okay. For this case, for the LAD, I think there's other factors. The diameter of the vessel. If you're dealing with a 2.5 and you're dealing with a 3.0 prox LAD and you're a diabetic, I think once you start getting above 50, you're going to probably get a TLR TVR. If you have a big 4 left main, a 375 prox LED, mid is 325, and you're at 50 and you're non-diabetic, and you get post PCI optimization, I think you should be fine. But there's other factors: diameter, diabetic status, and also the runoff of the LED. If you have a big wraparound LED, you have good flow. If you have a piddly little LED and you have a big RCA that wraps around to the apex, I think those are problematic. So there's some other factors. But once you start thinking about 50 or 60, problematic.
50 to 60, more than 2.5. It's
Like
good.
diabetes
It's good
and diameter size.
All right. Okay, thank you. Thank you, panelists. This is really enjoyable times. We're going to move to second live sessions about tabor procedures. You're changing panelist ears. All right. All right.